In May of 2014, 8 family medicine organizations came together to make a commitment. And our promise is that we wanted to ensure improving health care for the nation with family medicine leading the way to do that. So it's kind of a whopper of a goal, isn't it? And so we said, we're not satisfied with the way things are. And so our process for doing that is to get together a bunch of folks, gather some research from you and other constituents to create a 5-year strategic plan with some pretty ambitious goals, as well as the communications plan. The strategic plan is called Family Medicine for America's Health. Don't use the acronym FMAH, use FMAHealth. The acronym is a little naughty, so you're going to hear FMAHealth or the full name. The communications component of that is health is primary. And if you rode the subway in, you might have seen some subway ads that said health is primary. So we are getting out there. So today, the way our session is going to go is Lauren Hughes, who is a new physician on the FMAHealth board, is going to give you an overview of the project and target some specific information to family medicine educators and students. Then we've asked 3 students who, and gave them some questions that came from the FMAHealth core team on workforce, and asked them to go out to their constituencies because their voice is important. So you're going to hear some responses from them about what their constituents had to say about a few questions. And then we've asked John and Sam to kind of tie this up and ask and talk, what does this mean for you? And what can you do now to get engaged in this movement? So with that, I'm going to turn it over to Lauren to start and give you an overview.
Thank you very much. Can you all hear me okay? Good. Well, good morning. And as Stacy mentioned, my name is Lauren Hughes, and I am honored to serve as the early career representative on the Family Medicine for America's Health Board of Directors. And this morning, I'm going to walk you through, at a high level, the strategic plan that is known as Family Medicine for America's Health. And then I will also showcase some of the work that we're doing around the communications, the public-facing communications and patient education campaign that is known as Health is Primary. And I will reiterate what Stacy had to say about the acronym. If you want to know more about that, please come see me afterward. I'm not going to address that during the presentation this morning. So why we love family medicine. When I talk with medical students and residents about why they're choosing family medicine and talk with my colleagues about why we love what we do, there are many themes that I hear over and over again. Family medicine is intellectually rewarding. It's an opportunity to pursue lifelong learning, make a difference in our communities, and teach and empower others. But 2 themes in particular overwhelmingly stand out. Family medicine allows us to improve the health status of our patients and their families through meaningful doctor-patient relationships. But many challenges stand in the way of us being able to fulfill and honor those themes that I just mentioned. Spending is out of control in our country, and we don't have a lot to show in terms of translation of what we spend into health benefits for what it is that we are spending. Balance is off between prevention and treatment. We spend very little on prevention and public health, and yet we spend a majority of our health care dollars on preventing diseases that we otherwise could have prevented. And we've also lost focus along the way on our patients and on health. Our system is focused on treating conditions and diseases rather than patients and uplifting the health of our communities. As a result, much of the care our patients receive tends to be fragmented and uncoordinated. So in our current healthcare environment, we focus a lot of our attention on medical care, which has been estimated to only influence health about 10% of the time. By reorienting our focus on patients and communities and health status, we may see a much greater impact in the work that we do. Just over 10 years ago, the family medicine organizations came together and formed the Future of Family Medicine project, whose goals in many ways are similar to the overarching goals of Family Medicine for America's Health. The Future of Family Medicine project appreciated several accomplishments, including the increased adoption of the patient-centered medical home and encouraging meaningful use around electronic health records. But fast forward to over a decade later in the era of the Affordable Care Act, much work remains to be done to improve the health status of our nation. And into this need, Family Medicine for America's Health was created, which is a new collaborative strategic initiative of the family medicine organizations. And family physicians in particular are well poised to lead continued healthcare transformation. The 8 organizations that are involved with this effort you see listed here, including STFM, and these organizations have collectively contributed extensive expertise and resources for the duration of this 5-year initiative. So through Family Medicine for America's Health, we are launching a communications campaign and a strategic implementation effort with the ultimate goals of delivering on the triple aim of better care, better health, and lower costs. Broadly speaking, the strategic effort is focused at a high level on these areas. 1, to expand access to the patient-centered medical home, to advance the use of technology in a meaningful way that supports and strengthens the doctor-patient relationship and collaboration, to ensure a strong primary care workforce, and to shift payment away from a volume-based system with fee-for-service toward a comprehensive primary care payment that rewards value instead. There are 6 tactic teams that were recently formed in December that are charged with further refining measurable objectives around each of these areas that you see listed here, including practice, workforce, technology, research, payment, and engagement. And with the next 6 slides, I'm going to walk you through at a high level where these different tactic teams have chosen to focus their efforts for 2015. And please know again that we're at the beginning of a 5-year initiative, and so these areas of focus will necessarily evolve, change, and adapt over the next 5 years, depending on the needs of the campaign and the needs of the health of the American public. So the first team, the practice team, has established the goal of enabling family physicians and other primary care professionals to provide people with the right care, in the right place, at the right time, at the right cost. In order to do this, the practice team has established these following goals. 1, to build upon the success of the patient-centered medical home and to chart a course for its continued evolution. 2, to collaborate with other tactic teams to support family physicians in transitioning to a comprehensive payment model. And 3rd, to develop and execute a plan to ensure that everyone has an ongoing relationship with a family physician or another trusted primary care professional. Now on to the workforce education and development team, which I know will be of great interest and relevance to STFM. Led by Dr. Christina Kelly, the workforce team has set the goals of increasing the pipeline of students that are interested in pursuing family medicine and primary care, to increase and sustain interest in family medicine and primary care once they have indicated that interest, and to provide medical schools and residency programs with curricular toolkits that will emphasize skills physicians need to be successful in the future, including incorporating the entrustable professional activities, providing population-based care, practicing in a comprehensive payment system, and leading interprofessional care teams. On to technology. This team is focused on influencing changes in health IT that will help physicians more easily implement the patient-centered medical home, and supporting family physicians and their healthcare teams in using technology in a meaningful way to enhance the doctor-patient relationship. The research team has identified 3 areas that need our ongoing attention in terms of health policy and health services research, including the value of primary care and the role that patient-centered medical homes have in delivering that value, the efficacy of comprehensive primary care payment, and focusing on prevention, chronic disease, and population health. The research team also is very committed to providing patients and families and providers with tools to contribute information about health status and changes to inform ongoing research efforts. The payment reform team has established the goal of providing the highest quality and lowest cost primary care to people throughout the country. In order to make this possible, the team is focusing on cultivating partnerships with a variety of stakeholders and building the business case model to help patients and employers transition to comprehensive payment models. And lastly, engagement, led by Dr. Ted Eberly, and this is the team to which I serve as the kind of board liaison in my role. And we recognize that the engagement team, there's a lot of work to be done, and that we can't accomplish this by ourselves. And so we're working on bringing together a coalition of like-minded primary care professionals and patients to speak with a unified voice about changes that are needed in our primary care system, and also to strengthen advocacy on a variety of levels. So now I'm switching from the strategic plan to the public-facing communications and patient education campaign known as Health is Primary. Health is Primary was publicly launched at the October AFP General Assembly last year in Washington, D.C. And this campaign has the goals of demonstrating the benefits of primary care and engaging patients to work with us collectively in improving the health status of our communities. There are several specific values about primary care that Health is Primary is promoting, and you see these listed here. And these include the role of primary care in innovating how we deliver and pay for care, the role of primary care in prevention, and in enjoying the benefits of teamwork to help provide care, as well as the Get More FaceTime references the use of meaningful health IT to enhance, again, that doctor-patient relationship. And the Dots Connected poster, for example, is speaking to the role of family physicians and primary care providers in helping our patients kind of connect those dots and navigate the healthcare system. Health is Primary has several components to it, and the first is around patient education. One of the goals of the campaign is to create patient tools and resources for patients and families to use to improve their health. And this year we have chosen to focus on nutrition and exercise, chronic disease management, and immunizations. New themes will be selected for the years 2016 and beyond. We're also soon to be hitting the road with our City Tours campaign, which is the community engagement component of Health is Primary. The goal of these city tours is to highlight what is working in local markets for primary care, whether it's delivery, payment, outreach, health status, whatever the case may be, and to create opportunities for key stakeholders, including providers, patients, community leaders, policymakers, to share lessons learned about what's working for primary care locally and how those lessons can be used to accelerate primary care transformation in similar markets and other places. You see the 5 cities listed here. Raleigh is up on February 26th, followed by Seattle in the following month. And Detroit will be the last city tour of the year in October. Next year, we will have 5 new cities, so rest assured that we're going to be changing up the city tour scene based on geography and many other criteria as well. For more information about this campaign, how we got here and where we're going, I strongly encourage you to check out the very comprehensive supplement, The Annals of Family Medicine. This supplement was published in concert with the public launch of Health is Primary last October in DC. And also, I invite you to visit our websites and to sign up for regular email updates. Again, as I mentioned, our tactic teams just got created, and our figuring out the details of our work plans and measurable objectives moving forward. So there's going to be much work and much support that's needed in terms of filling out support networks to help carry out those objectives, and also specific local tasks that we'll need help with in moving this campaign forward. And our websites, as we move forward, will be the best place to find that information, along with other regular communication updates from the campaigns to the 8 organizations that are involved in supporting this effort. Thank you very much, and I look forward to your questions later on.
Thank you, Lauren. So you heard Lauren mention that one of the tactics that we're going to be working on starting in 2015 is about attracting medical students into family medicine. And so we really thought it was important to have students be a part of this presentation, to have their voice be heard. So our core team for workforce gave them 3 questions and asked them to go out to their constituents and get some feedback on that. So I'm going to start with Stephanie and ask her the first question, and then ask Mustafa and Philip then to respond as well, to give you a sense. So I'll ask you to be, there's going to be lots of time for questions, so be thinking of your questions as it relates to some of these students' responses. And I would love also to make sure students feel like they have an opportunity to come to the mic in a little bit as well. So Stephanie, in your experience to date as a medical student, has your exposure to family physicians, family medicine in the classroom and the clinical setting been adequate for you to enable you to understand and assess family medicine as a future career choice?
Awesome. So I think it has. I'm a student at Boston University, and at BU there's a large family medicine department who has diverse interests and have a large presence in the medical school. So we have family medicine who are deans and who are sort of the directors of the pre-clinical years and the clinical years. So the faculty really tries to inoculate students from the beginning, and there's classes that all first-year medical students take, like evidence-based medicine, and that's run by the family medicine department. And the Introduction to Clinical Medicine and Integrated Problems have a lot of family doctors who are leading those courses. And additionally, there's interest groups that have lunch talks and informal gatherings at faculty's homes. So I think students are exposed to many different family medicine faculty and can see how big the tent of family medicine is and all the different ways you can go with family medicine. And then moving forward into the 3rd year, we have a required 3rd-year clerkship that's 6 weeks long, and it sends students to community health centers and to private practices. So while you only have your own experience, when you meet for didactics, you can hear about students and their experiences at different sites. So I feel lucky that at our school, and the students who I talk to agree, that starting really in 1st year, there's a lot of exposure to family medicine and all that includes.
So Mustafa, you're a 4th-year medical student as well. Do you have any different responses from some of your colleagues and peers that you spoke to over the last few weeks?
Yeah, I'm going to give a mixed answer of yes and no, that I would say we had adequate knowledge about family medicine. So in terms of classroom setting, we had maybe 1 or 2 family physicians leading our Essentials of Clinical Medicine course and basically the How to Be a Doctor course. But aside from that, internal medicine has a strong foothold in a lot of our classrooms, and especially like specialties teaching the classwork, as well as PhDs teaching the first-year medical school classes. But there is opportunity to pursue family medicine if you're interested. So the specialty interest group, the family medicine interest group, so for those students that are interested, they can seek out lunch opportunities and dinner sessions and workshops. So there are opportunities, but you have to seek them out, and that's in the classroom setting. In the clinical setting, I would say I had an awesome opportunity that our school has a pretty, I go to the University of Illinois Chicago, and we have a pretty strong Department of Family Medicine, and they've set up a great rotation with sending the students out to various different clinical sites. So we have academic, community, and some that do lots of procedures, to some that do lots of OB, and some that do home visits as well. So get a really good idea of what family medicine is in the clinical setting. I would say not all schools have that, though. I've talked to peers at other schools who don't have a Department of Family Medicine. They have, say, maybe a primary care track, which doesn't mean family medicine. It could mean rotating with internal, general, general internal medicine, and you won't get to experience the full scope of what family medicine can do.
Thank you. Philip, what about your experience and your peers? You're a third-year medical student at Wayne State, right?
So I'm going to agree with Mustafa. I think one of the problems is that aside from the sort of introduction to how to interview patients and the translational med in the first and second year, if you don't actively seek it, you don't get that many experiences in family health. In the third year, we have our rotations, which across the board, all the students I talked to said were great. And we have this continuity clinic thing where you follow someone for 6 months, you follow a preceptor once a week, and that also really helps. But I think the problem is that a lot of times by the third year, people have either decided that family medicine isn't for them, or they decided they really like it. So I think there is some opportunity in the first and second year to expose people to family medicine that is not just the here's how to interview a patient and here's what translational medicine is. And I actually think there's some risk of sort of like pigeonholing family medicine docs into that kind of thing, because a lot of times when first and second year students are super stressed out about all the technical things they have to memorize, they sort of have a negative attitude going into these sessions. They're sort of like, why do we have to do this when I have my exam tomorrow? And I think that subconsciously affects the way they see family medicine. They're sort of like, oh, this is the fuzzy stuff that isn't really important. And I think that hurts them going into third and fourth year as they think about it.
So a little later, I'd like to hear from some other students in the audience about your perceptions on this. So the next question was, what do you see the role of family physicians in the healthcare system as it evolves over the next 10 years? And how would you like to see family physicians leading health system transformation to achieve the triple aim? So let's start with, that's not an easy question, huh? Let's start with Mustafa on this one.
The three of us were actually talking about what an awesome question the last one was. I think we're already seeing it with ACA and all these new patients that are coming to see family physicians. When I was doing my sub-Is, I would see patients in an outpatient setting who just got insurance. I'm like, yeah, awesome. But on the other end, family physicians, what we don't see is that some are really burnt out. We address the, okay, we got access to a lot of these patients, but we don't address the physician burnout rate, which we slowly are starting. There's an Annals of Family Medicine article addressing adding the fourth aim being physician burnout, but I think that's a step that we really need to pursue. I personally have worked with a burnt out family physician, and by the time I was working with him, I knew I wanted to do family medicine, but the whole time I was thinking, if other students worked with a burnt out physician, there's no way they're gonna go into family medicine seeing how overworked this physician is. And he is really passionate about his care. He's just doesn't have enough time. He's seeing too many patients and is too stressed out. And that's something I'd really like family physicians to work on.
Philip, your thoughts?
In terms of, the question is sort of also about what role that other students felt that family was going to play. And I think it's kind of interesting because I talked to a lot of students that weren't interested in family, and they're sort of like, oh, they're going to be like saving the world. They're going to be the ones that make all the difference, but I'm going to like leave that to them. So there's this sort of like this idea, and it echoes some of the research that was in this FMAHealth, right, not FMAH, article that was written. It sort of came up with these things because it said that like colleagues widely recognize that like this is going to be the answer. And that's what I heard from students. People would be like, you know, they're going to be the ones handling the social parts of people's lives. They're going to be the ones making the big change. But again, that answer was way more common in people that didn't want to go into family than vice versa, which I thought was interesting.
Interesting. Stephanie.
Going to say, I think similar to what both they said, but moving forward, family medicine is sort of in this unique place, I think, to help achieve the triple aim, and that the training really does focus on, you know, patient-centered care and social determinants of health. And even though we have a long way to go with physician burnout and everything, I think family medicine, more than any other field that I've rotated through, is focusing on medical student and physician wellness. So I think continuing that and keep going, I think family medicine will be well suited to help us achieve the triple aim.
So one final question for you all. You've seen the overviews of these materials. You heard there's an analyst article. There's other resources that are on the website, videos. How can we effectively engage the student audience in part of this movement? What are ways for us to do that? Certainly, social media always comes to mind, but what's the best tactics for us to be able to reach out and get people engaged and inspired to be a part of this? So let's start with Philip.
I feel like this is a topic that is at every one of these conferences. We always have people come talk to us about how they raise interest in family medicine at their schools, some really amazing clerkship directors who do that kind of work. I think a lot of it is breaking myths. That's why a lot of interest groups always have this idea of sort of like 10 not true myths and the Mythbusters idea. I think that a lot of engaging students is showing them how rewarding it can be to change lifestyle, because people are always attracted to things that are, as you guys know, that are like sort of, let's bring the patient into the surgery room, fix them, and send them home. And I think that instant gratification is a big thing, and people don't really see that with treating someone over time. And then people get really frustrated by non-compliance and things like that. So I think, again, it goes back to this idea that I think first and second year, it's important to have some kind of exposure through home visits or through a required sort of preceptorship in addition to these translational med classes and things like that for medical students to see these opportunities. And I think the other way to do that is to try to recruit more students who are excited, who come to these kind of conferences, to go back to their peers and report to it through their interest group or through whatever mode they have, because otherwise I just feel like people write it off without having a real chance to explore it.
Thank you. Stephanie.
Yeah, I think continuing to have leaders who are excited and passionate about family medicine and students having exposure to that early is critical. And I think I was talking with people at BU, but also even if some of these, not everyone needs to go into family medicine, but having that culture change of people who are excited about family medicine, who are in surgery and who are in cardiology, and that will also, I think, help sort of change the culture and students who go into family medicine, and it's not like, oh, you're so smart, why are you doing primary care, kind of attitude that I think is still in medicine.
Mustafa?
So I can think of two tactics that personally work for me. First one is FMIG, and some of you may know I'm really biased towards the family medicine interest group, but I think there's a lot of value in it. The FMIGs have leaders who are most likely going to go into family medicine, and those should be our target audience that we should go to, because they will be talking to all the students in the medical school. And AFP does have this national network of connecting with FMIG leaders, but I would say not all schools have a strong FMIG. But if we can connect with the FMIGs, they can disseminate information, talk to other students, and put on talks by awesome family physicians that ultimately get students inspired. They see a family physician talking at a lunch seminar, and they're like, I want to be like that person, and then they go into the specialty. They found a mentor. Another thing that worked for me was seeing that a lot of family physicians at my school address social justice. And so a lot of family physicians address social justice. It's just that they don't do a good job of spreading the message of what they're doing. A lot of family physicians, my faculty advisor always says, like, they do awesome work, but they don't do a good job of talking themselves up. We're all humble, and we don't want to talk about all the great social justice work we're doing. At my school, we have this longitudinal curriculum where we work with family physicians who work with domestic violence, geriatrics, homeless care, HIV care, and I'm forgetting one, refugee health. And just seeing all those people, our family physicians, was just such a positive, they were all great role models for me, and it made me realize this was why I wanted to do medicine. So if we can have that at all the schools, I think they'd be great role models, and to see that they're family physicians.
So before we move any further, I'm going to ask for you to thank our three students for their comments. We didn't tell them they were going to be on the main stage when we invited them to be a part of this presentation. So I appreciate their willingness to step up. So now I'd be interested in hearing from both John and Sam about their thoughts about reactions to what they've heard, ideas on what they think about engaging the membership, and any other comments they might have. So.
I guess as the past president of STFM, I put a lot of my time the last 3 years in working on this project. And I think now, as it's been launched, it's incredibly important that we understand what it can do and what it is and what it can't do and what it isn't. Family Medicine for America's Health, I don't think, is a project that's going to fix American healthcare for us. It is a process by which we together can figure out how to sort of start a brush fire, if you would. And I've been thinking a lot about Gail Stevens and about Gene Farley and about some of the founding generation of family doctors in the 70s that really launched and started a movement to try to fix what was wrong with American medicine. This has to happen in every family physician's office and in every family medicine department and in every family medicine clerkship. The order of magnitude of change that's going to be required to get this to happen is on the order of tripling student interest in family medicine. So you folks who run clerkships, we're not going to accomplish this with 8% of the medical students. We're going to need more like 30% of the medical students. Incremental improvements will probably, in my opinion, result in the failure of the Affordable Care Act to actually cover all of the American people and not break the bank. So the stakes here are really high. This movement, and it needs to be a movement, is going to work if everybody goes home and makes that happen. I don't think the Family Medicine for America's Health Board or the leadership of our organizations or even the leadership of our departments and practices are going to be able to do this. It's got to be something that everybody works on. So I think as you're finishing the meeting here and you're traveling home, I hope you'll search your soul about what that means for you, about what you are each of you, willing to do in order to try to actually get to this place where we can have the number and quality of primary care providers in the country to make the triple aim really happen. That's a very big deal.
Well, I agree. You know, in the vernacular of leadership and change management, this is known as a BHAG. Big, hairy, audacious goal. It's worth reading about it. It's a great concept. And anyone who thinks that we've assigned it to about 45 people, and when they're done, they're going to let us know, should leave the room like right now, because it's going to take absolutely all of us. It's going to be a huge process. The problem is that we're spending twice as much money as any other country in the world, and we're in a dead heat with countries that some of us wouldn't want to live permanently in terms of our quality outcomes. So we spend a ton of money, and our health care results suck. And actually, there's a lot of places, people, and organizations who would rather not have it change, given their choice. But yet, without change, right now, we're spending $1 out of every 6 spent in our economy is spent on health care, and we absolutely can't afford it, particularly when you're getting the results we get. So before we're done, the task forces are going to be assigning big jobs to organizations like STFM and others, and all of us are going to need to be knowledgeable, involved, and therefore I'm asking you to do 3 things. Number 1, I want you to Google Family Medicine for America's Health, and in the bottom right of the cover page, there's the opportunity for you to submit your email address so that they can stay in contact with you. You need to do that right now. You've all got smartphones. The ones who don't have got iPads. Do it right now. Number 2, then pull up your Facebook account, like I have, and like it and friend the page on Facebook for Family Medicine for America's Health. That way you can stay connected. And number 3, for those of us who are still trying to figure out Twitter, but also those of you who actually are actively involved, connect with Family Medicine for America's Health through your Twitter account. And then actually I lied, I said 3, actually I'm going to say 4. And the 4th is that eventually, within the next 12 to 18 months, I'm sure, the task forces are going to offload some stuff onto STFM having to do with the Family Medicine for America's Health. We're going to not only be assigning some of that to our existing standing committees, but we're going to have to actually create some new task forces within STFM to move forward with some of these initiatives. And those 4 things answer the question you should have had through this entire presentation, which is, how does this affect me and what can I do about it? We have not assigned this to task forces, like I said, who are all going to send us a memo when they're done. It's actually that all of us are going to have to be involved, just like John said. So thank you for coming this morning.